Wakai Medical University from Japan. It is my great honor to talk about our data here. Today, I'd like to talk about recurrence patterns after surgical resection for IPMN, no COI. To a certain effective treatment strategy to improve the survival and to facilitate appropriate post-operative recurrence, post-operative surveillance of IPMN patients, we analyze the patterns of the recurrence after surgical resection for IPMN. This is a retrospective multi-institutional observational study and included 1,074 patients who underwent surgical resection for IPMN between 1996 and 2014 at 11 Japanese academic institutions in a project of the Japan Pancreas Society. According to international consensus guideline definition of the radiologic morphological type, 47% of the patient had branch duct type, 36% had mixed type, and 17% of the patient had main duct type. Median follow-up duration after surgery was 54.2 months. Regarding surgical procedures, total pancreatectomy was performed in 9% of the patients, pancreatic duodenectomy in 59% of the patients, distal pancreatectomy in 29% of the patients, central pancreatectomy in 3% of the patients, and enucleation in 1% of the patients. Final pathological findings showed there were 45 patients with low-grade dysplasia, 32 patients with high-grade dysplasia, and 23% of the patients with invasive IPMC. In the result, among 1,074 rejected IPMN patients, 155 patients, 40%, developed post-operative recurrence at a median of 24 months. The recurrence sites were remnant pancreas in 70 patients, 7%, and extra-pancreas in 88 patients, 8%. We defined the recurrence in the remnant pancreas as the metacoronous development of high-risk lesions in the remnant pancreas, such as PDAC and malignant IPMN after surgery. First, we analyzed the cumulative incidence of the development high-risk lesion in the remnant pancreas after surgery. And we found 6.2% of 5-year cumulative incidence and 12.6% of 10-year cumulative incidence after surgery. This result indicated that development of high-risk lesion in the remnant pancreas could occur beyond 5 years after surgery, and lifelong continuous surveillance after surgery might be necessary for IPMN patients. Next, we compared survival from the surgery between the patient with and without development high-risk lesion in the remnant pancreas. We found that the survival of the patient with development high-risk lesion in the remnant pancreas was significantly shorter than that of those without. When we investigated risk factors associated with development of a high-risk lesion in the remnant pancreas for 994 IPMN patients after excluding of 80 patients who underwent total pancreatectomy for IPMN. Univariate analysis showed 6 risk factors: preoperative symptom, main duct type, IPMN located in the pancreas body or tail, main pancreatic duct diameter more than 10 millimeter, mural nodule size more than 5 millimeter, and pathological diagnosis of high-grade dysplasia or invasive IPMC. Furthermore, multivariate analysis showed 4 independent risk factors: preoperative symptom, IPMN located in the pancreas body over tail, main pancreatic duct diameter more than 10 millimeter, and pathological diagnosis of high-grade dysplasia or invasive IPMC. Among 70 patients developing high-risk lesion in the remnant pancreas, 36 patients underwent second operation for high-risk lesion in the remnant pancreas. We compared the survival from diagnosis of high-risk lesion in the remnant pancreas. We found that the patient undergoing second operation for high-risk lesion in the remnant pancreas had better survival than those without surgery. This result indicates that the second operation for high-risk lesion in the remnant pancreas might have the potential to improve the survival for remnant pancreatic recurrence patients. Next, we evaluated extra-pancreatic recurrence. In this study, 8% of 1,074 resected IPMN patients developed extra-pancreatic recurrence. We compared the survival between the patient with and without extra-pancreatic recurrence. The survival of the patient with extra-pancreatic recurrence was significantly shorter than that of those without. When we investigated risk factors associated with extra-pancreatic recurrence, univariate analysis showed 7 risk factors: preoperative symptom, mixed type, mural nodule size more than 5 millimeter, elevated serum CAEA, elevated serum CA99, pathological diagnosis of invasive IPMC, and positive pancreas cut margin. Furthermore, multivariate analysis showed 3 independent risk factors of extra-pancreatic recurrence: preoperative symptom, elevated serum CA99, and pathological diagnosis of invasive IPMC. When we classified 88 patients with extra-pancreatic recurrence into 5 groups, 26 patients developed only local recurrence, 19 patients developed only peritoneal dissemination, 19 patients lung metastasis, 10 patients only liver metastasis, and 14 patients multiple extra-pancreatic recurrence. And then we found that the survival of the patients developing peritoneal dissemination or multiple extra-pancreatic recurrence was the worst. The limitation of this study is it's a retrospective study, so selection bias may have occurred, particularly with respect to operative indications, variations in operation, preoperative examination, and surveillance protocols between surgeons and institutions. Such factors could limit the validity of these study findings. In summary and conclusion, first, metachronous development of high-risk lesion in the remnant pancreas could occur beyond 5 years after surgery, so continuous postoperative lifelong surveillance should be performed for all IPMN patients. Second, operation might prolong the survival for the remnant pancreatic recurrence patients. 4 independent risk factors associated with development of high-risk lesion in the remnant pancreas were found: preoperative symptom, location of pancreas body over tail, main pancreatic duct diameter more than 10 millimeter, and pathological diagnosis of high-grade dysplasia or invasive IPMC. Finally, extra-pancreatic recurrence, especially peritoneal dissemination, shortens the survival after surgery. So the same treatment and post-operative surveillance as those of PDAC might be necessary for IPMN patients with high risk of extra-pancreatic recurrence, including preoperative symptoms, elevated serum CA19-9, and pathological diagnosis of invasive IPMC. However, further prospective studies are necessary to confirm our data. Thank you for your kind attention.
Paper is open for discussion. I wonder if I can start just to ask you, earlier in this meeting, we learned that patients who had lung metastases following resection of solid pancreatic cancer had improved survival as compared to those with liver metastases, which was an experience that Dr. Tempero mentioned comports with our own at UCSF. I was wondering if you had seen similar differences in the prognosis of lung-only metastases compared to liver-only metastases.
Okay. So our data shows as a survival of the patient developing peritoneal dissemination is the worst. But also liver metastasis is the poor. But lung metastasis has a better survival than peritoneal dissemination or liver metastasis only.
It's a really nice study, a great longitudinal study, large sample size, over 1,000 patients, which is very impressive. So remind me, you defined high-risk recurrence as pancreatic cancer, all IPMNs, is that right? And there was one other thing too.
Okay.
Or high-risk lesions.
High-risk lesion including the PDAC in 23 patients and 45 patients in IPMN.
So
And
all IPMNs you defined as high-risk lesions for recurrence, yeah?
Yes, yes.
So one of the questions that we all grapple with is how long to continue to monitor or surveil these patients. Did you get a sense of, and it was striking to me that they could recur even up to 5 or 10 years after the original surgery. Did you get a sense of how, depending on the pathology of their original lesion, they were likely to recur? And you know, if someone has a low-grade side branch IPMN, for how long do we need to continue to surveil those patients?
After surgery?
Yes.
Yes. We believe that lifelong surveillance is necessary because even IPMN patients with low-grade dysplasia, their post-operative recurrence, especially high-risk lesion in the remnant pancreas, could occur beyond 5 years after surgery. So we believe that.
All of them?
Okay. Yeah.
Okay.
Yeah.
Great. Thank you.
Thank you.